Hello and welcome to Enhancing Clinical Practice stream of SNOMED CT EXPO 2020. My name is Farzan Ashrafi and I'm a senior terminologist at SNOMED International. I will be moderating today's session. Please use the Q&A box to type your questions to the presenter. All questions will be answered at the conclusion of the presentation. I am now pleased to introduce Dr. Russ Kridel, Chair of Board of Trustees, and Matt Manning, Director of Integrated Health Model Initiative Engagement from American Medical Association, who will be presenting Extending SNOMED CT to Design, Implement, and Track Programs, a CPT SMBP use case. Matt, please proceed.
Thank you very much. Full notes up here. We're happy to be here today. I'm Matt Manning, coming to you from one of the many home offices of the American Medical Association, where, as mentioned, I work on our Integrated Health Model Initiative. Also fortunate today, as mentioned, to be joined by Dr. Russ Kridel, who is chair of the AMA's Board of Trustees, among many other jobs. Dr. Kridel and I are excited to talk to you today about an important initiative at AMA to control hypertension and how SNOMED is playing a role. In 2017, AMA and SNOMED announced formal desire to work together. Since then, much work has been done independently and together to understand how collaboration can best benefit members of both organizations and where we get started. In the last year, ideation and development ramped up, led by Rory Davidson at SNOMED and Dennis Kassebaum at AMA. AMA and SNOMED demoed some of the value in connecting SNOMED CT to CPT codes earlier this week. If you haven't seen the demonstration project, which focuses on a breast cancer use case, find it through the EXPO app or reach out to me or any other AMA attendee after the presentation. For the rest of our time today, we'll continue the discussion and focus on another way that AMA informatics experts used SNOMED CT as the foundation for tools that improve the ability of clinical care teams to make data-driven decisions and to map those SNOMED concepts to CPT to enable improved remote monitoring programs. Dr. Kridel will set the stage with an overview of AMA's strategic arcs and our focus on self-measured blood pressure, SMBP for short, which is an acronym that's going to come up a lot in this presentation. Dr. Kridel, if you'd lead us through the overview.
Well, thank you, Matt. I appreciate that. The AMA is organized around three strategic arcs. The first, to lead the charge to confront chronic disease and public health issues. The second is driving the future of medical education. And the third is to remove obstacles that interfere with patient care. So developing standards and tools to enable self-measured blood pressure programs advances objectives across all three of them. For the first, clinical evidence-based tools that help clinicians and their patients monitor hypertension from home can improve outcomes for populations with high blood pressure and also can reduce the need for office visits, which is especially important during a pandemic. And it involves patients in their own care and empowers their sense of personal responsibility to take a role in their own health. Secondly, as far as medical education, we are innovating with modern-day curricula for medical students to help them adapt to a new technological health world. But medical education isn't just for doctors, especially as we establish effective remote monitoring programs. Once the clinical guidelines for best practices are established, patients, care teams, as well as physicians require training to generate and analyze clinically trustworthy SMBP readings. And third, to eliminate barriers to trusting SMBP data and provide tools to measure utilization and health outcomes. So across all three arcs, AMA strives to identify and address inequities in health outcomes and the way healthcare is provided. So it's important to acknowledge here that, unfortunately, the basic resources needed for the kind of digital remote monitoring program that we're discussing and developing will not be available to many individuals affected by hypertension yet. So providing clinically valid Bluetooth-enabled home monitoring devices, supporting access to reliable Wi-Fi and mobile devices, and partnering with leaders in communities most impacted by health inequities are some strategies for ensuring equal benefit from the digital SMBP programs across hypertensive populations. Now, it's worth talking a little more about why hypertension and self-measured blood pressure specifically are priorities for the AMA and IHMI. Those are the initiatives that we're working on at the AMA at this point. One of the challenges that we've encountered when developing data standards is identification and prioritization of use cases that meet a need for clinicians and will be adopted by industry. So the two must work together if we wish to achieve our goals. Now, let's look at the severity of the problem. Nearly half of US adults have high blood pressure. Now, that's a leading cause of heart disease, stroke, kidney disease, all around the world. So high blood pressure is frequently undetected and undiagnosed because in the beginning it has few, if any, symptoms. But if it's left untreated or undertreated, the effects of high blood pressure can be devastating. So controlling high blood pressure for all people is critical to reducing the roughly 800,000 deaths that occur in the United States alone each year associated with heart disease, stroke, and kidney disease. And this is especially true for Black, Hispanic, Latino, Asian, and Native American populations. These are adults who are less likely to have their blood pressure controlled due to longstanding social, sometimes cultural, economic, and structural differences. So, now it's even more complex because mounting evidence shows that high blood pressure may be associated with worse health outcomes for patients who have COVID-19. So this increases the concern that America's healthcare disparities in blood pressure control may be contributing to the disproportionately high death toll of COVID-19 patients in marginalized communities. Moreover, individuals with hypertension and other chronic diseases are delaying care for fear of COVID-19 infection. They're not going to the doctor's offices. So here's an opportunity. There's the significant increase in telehealth visits, including hypertension-related visits, and it holds promise if patients and physicians have the support that they need to achieve effective remote care. That means ease of use, instruction, and adequate reimbursement. We also work internationally to prioritize use case development and join forces with partners who can achieve a global impact. Now, unfortunately, unmanaged hypertension is not just a problem in the US. Prevalence, as all of you know, is increasing throughout the world and is concentrated in low and middle income countries. So the AMA seeks collaboration with partners internationally who are developing foundational standards, programmatic approaches to patient and clinician education, and accessible, reliable tools for collecting and analyzing self-measured blood pressure readings that can be shared globally. Innovative approaches to health data capture and analysis rooted in evidence-based medicine can help slow or control increasing prevalence of high blood pressure. Now, the AMA collaborates with the American Heart Association on the Target BP program, which aims to provide every American adult with education about high blood pressure, including how to self-measure it at home, self-measured blood pressure, SMBP. So when performed properly using accurate devices, and that's key, SMBP monitoring can be a useful and convenient adjunct to conventional office-based care by reducing the need for frequent office visits. In fact, when combined with phone or web-based support plus clinical counseling, SMBP monitoring has been shown to lower blood pressure and improve blood pressure control. Now, equally important is that every physician and care team be equipped with a data dashboard, as well as access to proven evidence-based clinical support to improve blood pressure control. Giving clinicians timely views of their population of patients against relative metrics for achieving blood pressure control and stratified by race and ethnicity, it can be a game changer. Yet most healthcare organizations currently do not have this view at the ready. We have to work on that. So given the added ability to drill down to each patient's data, including self-measured blood pressure readings, physicians and their patients can better tailor care management. Thank you. Matt's going to continue now. Matt?
Thanks for the good context, Dr. Kridel. I'll go on now to talk more about our informatics and standards journey with self-measured blood pressure. And it's fun to do it here. The SNOMED Expo is one of the few places where I've had the opportunity to report progress on a specific informatics initiative annually for many years. I think this will be the third year that I've talked to you about the Integrated Health Model Initiative, with a few more focused on CPT before that. As a reminder, IHMI, the Integrated Health Model Initiative, started as an effort to build semantically interoperable data models that could be used as standards for clinical data exchange across healthcare. Over the years, we've pivoted from a focus on development of AMA-authored standards to support for interoperable standards in HL7. But we've continued to expand our clinical informatics expertise, along with our support for key projects in FHIR and with SNOMED. We've also recognized the need for easy-to-adopt tools that utilize standards and respond to priorities for clinicians, so I've extended our work to build digital tools beginning with SMBP. It's been an interesting progression for me, with SNOMED as a through line from our initial work to translate clinical guidelines into common medical terminology for SMBP in SNOMED CT, to collaboration with folks at HL7 and HealthLogica to come to agreement on modeling and terminology, to development and hopefully later this year adoption of software that leverages those models and the links between SNOMED and CPT. To finish out, let's briefly review the use case that we worked from, look at examples of the underlying SNOMED CT concepts and CPT codes. We'll look at the workflow where we're leveraging those standards, and then how we use clinical data in AMA's SMBP portal. A patient in this scenario performs SMBP measurements at home using a clinically valid device per the guideline. Measurements are encoded in SNOMED CT, transferred to a cloud-based app, processed and averaged, and then transferred along to an EHR for analysis. I won't go deeply into technical details, but wanted to give a few examples of what it looks like to convert clinical guidelines into computable medical terminology. It seems simple, but developing comprehensive value sets, terminology, and data models took years of collaboration with clinicians and informatics experts to build consensus, test, and revise. Meanwhile, the CPT editorial panel convened experts from US specialty societies, payers, and government in an evidence-based, deliberative process that took a similar amount of time and work to establish sound CPT codes for SMBP procedures. All of this work was facilitated and supported by dedicated teams at AMA that we continue to grow. I talked earlier about the importance of aligning clinical priorities with standards development, and I'm stressing the amount of time and resources needed to do this work now to make the same point. Clinically valid standards are the necessary foundation of all the work we do in health information technology, but an implementation guide or a terminology value set is hard to make exciting, and the time and resources needed are costly. We must be able to demonstrate that the significant investment organizations, governments, and volunteers are making results in measurable improvements to health and healthcare operations. Venues like the SNOMED Expo are some of our best opportunities to share priorities, align our work, and identify and accelerate health information technology development that benefits clinicians and patients. And in IHMI, we're developing tools that will allow us to measure adoption and impact. Generating accurate, actionable, self-measured blood pressure readings requires programs for training patients to take measurements per clinical guideline, devices that have been clinically validated and capture all of the data required by the guideline, mobile apps to exchange SMBP data with EHRs and blood pressure monitoring clinical dashboards, and tools for utilization documentation, billing, quality reporting, and analysis. Our goal, as you heard earlier, is to leverage work with partners from the American Heart Association to SNOMED to provide programs for treating patients where they are and giving clinicians a complete view of patient and population health. Here's a look at a clinical dashboard from AMA's SMBP app. SNOMED value sets and FHIR information models allow consistent retrieval and exchange of SMBP data, including necessary, often missing detail like patient state, cuff size, etc. Patient-generated data can be combined with clinical and demographic data from the EHR to track adherence, average daily, weekly, and monthly measurements, and establish the criteria are met for billing documentation and quality measurement. Our goal is to provide clinically accurate data with clear provenance rooted in standards on every screen. Here are a few more screenshots showing ways we use standardized data to track and identify clinically valid devices, leveraging the US BP Validated Device List, another resource AMA collaborated with the American Heart Association to develop. And in the second screenshot, dashboards for viewing granular SCT encoded BP data at the population level. Remote monitoring device adoption was accelerating before the COVID-19 crisis, and RM programs are being considered with urgency as healthcare systems respond. Clinical standard developers and professional societies can ensure that remote monitoring programs are rolled out not just more quickly, but with data exchange standards that are open and interoperable, quality controls rooted in best practices, and efficient use of coded clinical content for multiple downstream uses. Collaborating around common priorities like remote monitoring can accelerate development of tools like AMA's SMBP portal. Bridging to administrative insight in CPT codes using SNOMED CT encoded clinical SMBP data is one way that code set integration can improve SMBP program development and utilization analysis. It's been great to talk to you today, and we appreciate you spending time with us at the Expo, though we regret missing the opportunity to interact with you face-to-face. We are excited to hear your feedback and happy to answer questions in the remaining time. Thank you.
Thank you, Matt and Russ, for your presentation. Can I ask that attendees give us a moment while we switch over from our pre-recorded content so that the presenter can address the question you have been submitting live Please also note that this session will be available on the event platform for the next 3 months. Thank you. Hi, Russ and Matt. Thanks for the informative presentation. We do have a few questions posted on the Q&A box. Going through them so I can share them with you and the audience. The first question is, were there any particular challenges that you encountered in using SNOMED CT to support this remote application?
Yeah, for sure. And I think this is the part of the presentation where I refer you to other folks back at the AMA. The two folks that did the most work to build the initial SNOMED CT value sets, this was 2 years ago when we were first starting to build proprietary profiles and then FHIR profiles, were Corey Smith, who directs our informatics work, and Dr. Monique Van Berkom, an expert on the informatics team. And I think in brief, the biggest challenges were gaps and duplicates. You got a tremendous amount of back and forth with clinical experts first, just to parse the guideline into information that can be translated into concepts, and then matching that kind of clinical information to either existing SNOMED CT concepts or determining through that same consensus process that new ones are required. Just took a tremendous amount of time. I think that's necessary work, but one of the questions that we kind of keep circling back to is, how can we accelerate that? I talked a little about that in the presentation yesterday, in the hope that identifying common clinical priorities is one way to bring people together to accelerate that consensus building process. But I still think that's the biggest challenge that we've got, narrowing to repurposable terminology for everyone on these key domains.
Okay, thank you. The other question is that this might be a more general question, but where would you like to see the AMA and SNOMED relationship go?
Yeah, a great question, and one I hope we've been kind of laying out a roadmap on for the last few years, and a little more concretely this year. I talked a little about the Integrated Health Model Initiative, the unit that I work for. We work with our friends in Health Solutions on CPT, but on some kind of different projects. That said, so much of our work grew out of an understanding that we needed better data, better terminology and informatics integration if we're going to achieve all those lofty goals of interoperability and better data for docs and patients. And such a huge part of that is reducing the complexity in the way that we code all of this information. So the ability to use SNOMED as your foundational terminology across the board, but then fairly seamlessly flow that down to the more specific terminologies necessary to categorize information around clinical data or information attached to clinical data is going to become incredibly important. And I hope that we continue to integrate those two code sets to give folks that ability to code once for clinical and then handle all of their administrative needs without a loss in fidelity or good information.
Okay, the next question is back to the mapping between the CPT and SNOMED. For the mapping, did you stay with the exact mapping with the CPT and SNOMED, or was there a degree of correlation, narrower or broader relationship between the two?
It's a great question as well, and brings us from the broad and general to the specific on the CPT-SNOMED relationship. It depends a little on which way you're mapping, and this is another area where for good detailed information, I would refer you to our booth, where experts can kind of get into the details of how those maps work. But very broadly, there are about 10,000 CPT procedures. CPT is a lumped terminology, and of course, over 100,000 SNOMED CT concepts. So when mapping from CPT to SNOMED, we're typically giving a range of codes and then prioritizing those codes based on how good a match they are. We also provide a map from SNOMED back to CPT. That, of course, is going to be the inverse, where you're going to arrive at a single CPT code, but you may get there from a number of SNOMED concepts or combinations of SNOMED concepts. A lot richer data to share there, but probably more than my expertise or our time allows. So again, the AMA booth is a great place to start to learn more about how we're connecting those two terminologies.
Yeah, for sure. I also encourage people to come to your booth and ask questions. And I think that we have one more question here, and it's regarding the development of patient-friendly SNOMED CT term. How do you feel? How the physician would feel about that?
Yeah, I'd love to learn more from Dan about the kind of context for that question. I think, and again, this is where we should get perspectives from some of the informatics experts on the team, but we're broadly happy to get docs whatever language is going to best help them understand the health information that they're getting and communicate it back out. There are, of course, a lot of patient-friendly terms for SNOMED CT concepts out there, a lively industry in creating those in the US and globally. I think what jumps out to me immediately is kind of circling back to Brenda's question at the beginning. How do we ensure that there isn't so much duplication in these terms that they become unusable? How do we be sure that there are clear connections back to the core concepts and that they can be mapped on to data consistently and accurately? Generally, though, folks should be able to use the language that is natural for them to do their work.
Okay, I think that those were the questions that we had, but I'm sure that people are more interested in the topic in general, and I encourage them to come by the booth and ask the question directly from you. Thanks everybody for joining the call.
Thank you all.
Bye.